Mark Siegler is a very prominent person in the world of ethics and medicine. And he once wrote that philosophers, people who teach and study that sort of rarefied stuff in liberal arts colleges, can only have the counterfeit courage of non-combatants. I mean, by which he really meant that there's something special about philosophy, but that something special can't cure you. It can't make your mom feel better when she's dying. It can't bring wholeness even to a conversation about philosophy, because there's something special about a hospital. And that may be true. What it does, though, is raise a very, very important question, one that's not only at the heart of bioethics in contemporary society, but at the question of how you learn to do it. Who can do clinical ethics? What is it? What kind of expertise do you need in order to be effective in a hospital? According to Siegler and others, the people who ought to be treating patients are the people who treat patients. The Code of Ethics for the American Medical Association says the first duty, the most important ethical responsibility, is to be competent. Hard to argue with that, right? We don't want doctors who trade their clinical expertise against their political agenda. We don't want doctors who are incompetent but well-intentioned. And in fact, every medical television program has had at least one episode about that person who used to be the really amazing doctor but isn't anymore, and the struggle that people have to kind of bring that person out of medical practice, even though they're the soul of the operation. The thing is, though, that medicine has changed, and saying that's almost a truism, but it's changed not only in the last 10 years or 50 years, it's changed in the last 10 months. We, every single year, undergo a complete revolution in how medicine is paid for. Every single year, a new drug is announced, usually 3 or 4, that will change the way we talk about at least one major disease, whether it's diabetes or heart disease. New tests are released monthly. The newspapers now have a health or science story on the front page every day that report any from a wide range of different new discoveries that affect parents, children's, and grandparents' lives. It's so complicated to be a doctor now that among the most important complaints doctors make is that they can't keep up with the kind of Google printouts that patients bring in. They don't know their own specialty as well as the search engines and aggregators do. So complexity, a difficulty being a patient these days because you just don't know what you're going to find out. Maybe you should have had vitamin E to prevent Alzheimer's. That level of intense new knowledge and where it happens, the modern hospital, coupled with revolutions in how we pay for health care, how we think of ourselves when we're getting our insurance, that's just about enough to confuse anyone. No one in America understands health care. We reduce it to sound bites. We talk about whether we want socialized medicine. So now take that all the way back down to the bedside. When doctors 10, 15, 20 years ago were grappling with cases about end-of-life care, it made sense to say that if you're grappling with end-of-life care, you need a doctor, because end-of-life care is fundamentally about your lungs and your heart and the variety of other clinical factors that come into play when you decide whether or not to flip a switch and turn off the respirator. One of my favorite examples of such sort of straight-up decision-making is the law recommended by a large group in Israel that has created respirators throughout that country that run like a parking meter. So in an effort essentially to avoid confronting the question of withdrawal, which violates violates Jewish law in the view of the highest group to consider it, they essentially created a mechanism whereby you have to set a timer to keep a respirator running. And when the timer runs out, well, the respirator isn't going anymore, but nobody turned it off. Machines aren't like they used to be. Most of the things that keep people alive don't have a switch on them. And so whether you start certain kinds of care or stop certain kinds of care, those decisions really can be made by nurses. They can be made by any of a variety of different kinds of people who even 10 years ago weren't even involved. There have been scandals about the involvement of drug and device representatives in operating rooms, but that's not what I'm talking about. What we're talking about in clinical ethics today is incredible complexity, and who's to help. It may very well be that there are non-combatants. I don't think anybody wants to see the creation of a real new specialization where people who don't know a thing in the world about medicine go into hospitals and try to help people. It wouldn't work, frankly, because if you can't speak medical, if you can't read a chart, if you don't understand what people are talking about or what the beeps and chirps and twerps mean, or why people are running to and fro, or who these people are and the length of their coats and so on, the politics, the visual show that is medicine, particularly in an intensive care environment, you got to know that. But can you be a non-combatant? Well, I think we've reached a point in American society where pretty much everybody agrees that the answer is yes. Non-combatants deal with clinical care all the time. I don't know if people who are in hospitals who don't participate in the active day-to-day provision of healthcare are non-combatants or not. I can see how a lot of my friends who are trained as philosophers, the last thing in the world they would want to see themselves as is a doctor, let alone a combatant on that military metaphor. But I can tell you there are a lot of strangers, a lot of people who aren't actively engaged. They aren't even giving vaccinations. They aren't actively engaged in interventions, and yet they're there in healthcare. Chaplains who provide something that can only be described as odd when compared to the sort of thing that goes on in a neonatal intensive care unit. Nothing a chaplain does will provide a measurable outcome. And believe me, there's been plenty of attempt to try to prove otherwise. Strangers at the bedside, to borrow the title of perhaps the best known of the histories of the relationship between bioethics and the media and the world, these strangers at the bedside who are interested in ethical issues, well, let's just say they are indeed strange. And the ones who aren't trained as doctors, and even the ones who are, who come into the picture because they want to help solve a problem, they're there not because they believe they can solve, you know, they can change the diagnosis. They look at a bone and it appears really not to be broken, or they look at a test of a pregnant woman and gosh, it's obvious to me from this picture that baby should never be born. That's not it. The key isn't either that they have the sort of ordinary consultant's expertise. They are consultants, no question. They're employed as consultants in many cases. But most of the time a consultant will say, something's wrong, and here's what I do. An ethics consultant might say that as a stranger, but even when they do, they, in saying so, are coming to the case with a kind of training in the whole history of not only codes of ethics in medicine and the other specializations that comprise our healthcare system, but also training in the law that makes medicine work and makes hospitals work the way that they work, and especially the law where it is completely undefined, which is most of what we deal with in bioethics. And hopefully they have some training in the social sciences. And so that, by which I mean really that they understand how we measure things, what the metrics are, and how they've developed, what's the history of those metrics, what's the yardstick for health. So there's this radical proposition, and it's the one that Martha Nussbaum makes, and that is essentially, not only can the people from the outside world, people who don't come from medicine, or, and this is very important to say, or those who are active clinicians who come from right inside the world of medicine or science or health policy or insurance, can those people, when they step outside, in the latter case, their professional role, or in the other case, the philosopher who kind of wanders into the clinic, or any other stranger who wants to work in ethics, can those people not only belong in the hospital for purposes other than visiting their family members or being sick, but can they actually cure you? And I think it's an interesting question. So I'll advance the radical case. The radical case is this: every aspect of healthcare is defined by a social consensus that, as it were, creates the context of healthcare. Everything we decide we'll treat, the degree to which we decide we'll pay for it, the ways in which we decide we'll provide the care, the people we train, how much money we make them borrow to go to school, all of that is structured by a set of social conversations. So there's only so much space in shelters for response to a biological attack in New York. If there were an attack with biological weapons, only so many people could live. The system is designed that way. Triage is, in a way, the best illustration of the fact that we make decisions about what we can afford to do. And health fits into a broader array of priorities. So, there's only so many beds for little babies who are born premature. And when there's no bed, then there's no bed, and that's it. If you can't transport someone the distance that's required in time for them to have health care, then they don't get it. And so it seems like a truism, but when you elect to live in the middle of Montana, then for the purposes of health care, you're going to have some problems if you have any kind of complicated medical issue. It's very much like, though, living on the coast of Florida, in the sense that we all make decisions about risk, and more importantly, as a society, we make decisions about how we'll structure what we'll pay for and what we won't. It's more than money, too. It's the actual description of what a disease is. Is an infertile person diseased? I mean, a woman who was 68 years old had a baby in 2007, right? She gives birth, and everyone around the world says, wow, it's gone up from 63 to 65, from 57. People are beginning to sue when in vitro fertilization clinics won't provide the care. Is a 68-year-old woman infertile? And what does it mean to be infertile? Are you infertile after we provided the first child? Is that just a financial decision? And what if the only way you can be made to have a child come out of your vagina is to use the sperm of one person you don't know and the egg of another person you don't know, and the resultant birth is someone who's not biologically related to you in any ordinary sense from years past? The laws in most states would say, well, that's your child and yet not, right? It's very difficult to parse what it is to cure infertility. Maybe that's an exception, but maybe it's not at all. Right? Are you sick if you have the gene for breast cancer? I don't know. You're not symptomatic. Let's assume you don't have a tumor. You don't actually, and here it is, have cancer. Well, so that's the kind of question that just is strange, but more importantly, it requires strangers. And so our entire healthcare system is, some will complain, populated by MBAs, by business people who with calculators sit around and figure out what we can afford to pay for and what we can't. But more important is what happens at the bedside. When someone gives birth to conjoined twins, when in a more ordinary setting, someone says about their mom, and this happens every day in hospitals around the country, we know she's dying. We know that the respirator attached to her is keeping her alive artificially. As soon as you turn it off, she'll die because there's no way she can live without the respirator. And in fact, even the respirator is killing her, just slowly. We know that our mom's brain activity, to use a slightly different angle, is near none. But her only son, who lives in Hong Kong, cannot get here for 2 days. Keep the respirator on. Right? These are the sorts of decisions that they don't prepare you for in medical school. They don't, because it's not a pathology to not have your son with you. It's not a pathology in any ordinary sense of pathology, the pathos, the having a disease, right? Doesn't work that way. They teach you with slides and with cadavers. And when you cut somebody apart, what you don't find is what Plato was talking about when he said that, what philosophers do, what we all ought to do. And at the time, philosopher, doctor, it's all kind of coextensive. And he was talking about doctors, as Martha Nussbaum points out, is you cure your soul. Not your Christian soul necessarily, but your soul. So at bottom, what is healthcare? At bottom, healthcare is the decision set we make about what we'll do in every aspect of human health and disease. And clinical ethics, at the periphery of that set of decisions, kind of treats the worst symptoms of our very, very human, our all too human inability to come up with any real agreement about what counts as health. Clinical ethicists show up because doctors who aren't clinical ethicists call them. We get paged in my medical institution 100 times a year. Well, that's not true. It's many, many more than that. Hundreds of times a year. And 100 times a year or more, an ethicist shows up and does a consult. Now, it's not Socrates with the beeper we're talking about here. It's a person who participates in what looks like a communication problem. Even the ethicists will most often say it's a communication problem. But what they're communicating about is on the periphery of who's sick and what does it mean? And what does it mean to make you well? And I think there's a very strong argument to be made that curing you, at the end of the day, curing you is as much about making sure that we've described, defined, and worked to make a healthcare system that helps you live a full life, that associates health with flourishing. You know, not just happiness, not just, you know, a good time, but flourishing. Rather than just the strict, fairly easy to describe set of symptoms that we can relieve and therapies that we can provide to relieve them. Clinical ethicists are here, whether they're on TV or at the bedside. They're here because people want to have a rich conversation about that rather than, you know, just kind of arguing about it over a couple of beers, even though that's fine too, or screaming at each other because these things happen at the very worst time. They bring out the very worst aspects of every human relationship, and they often kind of put people into autopilot.